today. Now it's a turn of Dr. Ronald. Hello. She's Mary from India, and he's Ronald from
Hello.
United States.
Hello.
Thank you all for the welcome. Good morning, good afternoon, good evening, wherever you may be. I'm Ronald R, a clinical psychologist and clinical professor with Arizona State University. That's located in the Southwest United States in the city of Phoenix, the state of Arizona. But I work remotely. I teach online. I work and live near Boston on the East Coast of the United States. So I'm happy to see you all today, and I really enjoyed Mary's presentation. I'm a huge fan of digital health, not just the kind of things you showed, resources to help clinicians, but the increasing availability of smartphone apps to help patients learn how to manage their health more effectively, mental health and lifestyle exercise. So a great presentation, Mary. I really enjoyed that. And
Oh,
also my colleague Habib. I know Habib for quite a while now. I've been doing training for his social workers in Bangladesh. So great to see Habib's presentation also.
yeah.
So I'll
Thank you
share my
for your
screen now and get,
words. Now I will present you. I will present you,
okay.
Ronald. Okay. Let's see. Our friend and colleague Ronald O'Donnell is a clinical professor, psychologist, and founding director of the Doctor of Behavioral Health Program 2008 and 2014 in the College of Health Solutions at Arizona State University in Phoenix, Arizona. He is president of Suncrank Health Solutions, an international behavioral health consulting company. Dr. O'Donnell maintains a psychotherapy practice in his local community. Dr. O'Donnell is a leader in the research, education, and training on global integrated behavioral healthcare, the use of behavioral intervention to improve both medical and psychiatric problems such as diabetes and depression in a global context. O'Donnell has led the development of the Doctor of Behavioral Health degree curriculum and internship training program and expansion to include both clinical and health management concentrations. O'Donnell is now working on the development of international education programs for the College of Health Solutions, as well as the development of new integrated healthcare degrees and physician certificate education programs. We are very happy, and it is an honor to have Ronald as one of our speakers at this Congress. Thank you so much, Ronald.
Thank you, Carolina, for the wonderful introduction. I'm very grateful for the invitation. Thank you. So this is my first time doing a presentation for Peru or South America. I've been doing work globally. I always share my contact information. So if you have any questions for me after my talk, feel free to email me, contact me on WhatsApp. I'm happy to talk to any of you anytime in the future as I try to promote integrated healthcare globally. My own work has been both a consultant and a trainer. I did many years of work traveling to China, training physicians and nurses, psychologists, and social workers there in integrated healthcare, doing work in Southeast Asia since around 2015, 2016 in Vietnam, Thailand, Cambodia. In the last few years, I've extended my work to working with colleagues in India, Bangladesh, and just this year, Ghana and Nigeria. I'm currently a consultant for the World Health Organization in Vietnam, where I'm helping to write the first guidelines for psychological interventions for psychologists in Vietnam. I'm a clinical faculty. I'm not a full-time researcher, but I do some research projects. I'm currently leading a 5-year grant training social work intern students in my university in Phoenix. We have them learning online integrated healthcare. I've had some small seed grants and other grants to promote integrated healthcare globally over the years. So my talk will begin with integrated healthcare. What is it? Why do we need it? How do I learn to practice integrated healthcare? I'm going to cover a lot of slides today, so I'm going to go quickly and save time for question and discussion at the end. And of course, you can have my slides available in the presentation after the talk and talk to me if you have more questions on things I covered today. So the problem we're facing globally is a triple epidemic. We have COVID-19 that caused so much disruption and harm and is still with us and still causing illness and pain and death. We have non-communicable diseases like type 2 diabetes and hypertension, which are increasing globally. And the reason they're increasing is largely because of our lifestyle, how we behave, how we act, what we do. How do we exercise or not? How do we eat healthy or not? Do we drink too much alcohol? Do we use tobacco? These are all the reasons that chronic diseases are increasing so much globally. And then mental health. We've seen an increase globally in mental health problems across the globe in psychological problems like depression. So we also know that non-communicable diseases, unhealthy habits, and psychological distress are all related. If you have a chronic illness like type 2 diabetes, you're likely to be having depression also. If you're using alcohol, you may have health problems, of course. And we know from research on COVID-19, if you are infected with COVID-19 and you have existing medical comorbidities, diabetes, hypertension, obesity, your risk of having a poor outcome, either being sicker or even dying from COVID, are worse if your health status is poor. We have a workforce problem. Imagine you go to see your family doctor. You're not feeling well, you're feeling kind of run down, you're not sleeping well, you're tired, fatigued, and you go through all kind of laboratory testing and you see your doctor and he says to you, well, there's nothing medically wrong with you. Maybe you're just stressed out or depressed. And you say, well, what can I do, doctor? He says, well, maybe you could see a psychiatrist for depression. How about my sleep? Well, maybe some medication for your sleep. The problem is our workforce of physicians and nurses, they're excellent and doing a great job with medical care. They're not trained to offer us advice about how to improve our health, how to stop smoking, how to eat healthier, how to manage depression. Their only solution is medication, which of course medication is important, but we're missing the other side of the equation. How do we address our health behaviors? So there's a need for education and training for our medical colleagues in this area. Along with the previous presentation, there's a technology problem. We have emerging digital health technologies, online resources, like the prior presentation just showed you. We have smartphone apps for depression, for diabetes, for meditation. Increasingly, if patients have diabetes or hypertension, get a Bluetooth device and measure their blood sugar and their blood pressure at home via Bluetooth and have their doctor know what they're doing miles away. So great technology, but unfortunately, even though it's becoming widespread and consumers love it, consumers love health technology, digital health technologies, most of our clinicians are not recommending this to patients yet. So integrated healthcare, what is it? It's a way to integrate physical health and mental health, bring them together and treat them in a holistic way. It involves, of course, the healthcare system being redesigned to incorporate this, managing health outcomes, not just for medical, but for mental health, for lifestyle, training for healthcare professionals, and addressing basically physical and mental health in a way that is seamless and gives the patient one-stop shopping. So the definition in the United States is a practice of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care. It may address substance abuse, mental health, health behaviors, lifestyle things like exercise, physical activity, diet, nutrition, life stressors, crises, physical symptoms that are tied to stress. That's integrated healthcare. In the United States, it means oftentimes a clinician like a psychologist or social worker working right in the family doctor's office with the primary care physician team, having an office there. So if the family doctor says, oh, you have depression, go walk down the hall, please, and see my social worker. She'll help you with depression. Oh, you need to lose weight? See my social worker down the hall in her office. She can talk to you about exercise and diet plans to help you lose weight. It's one-stop shopping, and increasingly in the United States, social workers are filling this role, and they're doing psychotherapy, health coaching, lifestyle counseling. These are all things social workers in the United States are doing increasingly. It's a major source of jobs for social workers now in the United States. That's a good thing. Now, I know in most of the world, that's not the case, especially in developing countries. In my work in China, Southeast and South Asia, this is not the case. Social workers are doing good work, case management, finding resources, helping families, but they're not really doing psychotherapy, health coaching, integrated healthcare counseling. There's a need for that. And my talk today is about what are the competencies a social work needs to become integrated healthcare practitioner? So ideally, the social worker will be in the primary care clinic or in the community. I understand there's no primary care clinic availability for many social workers, but their role is to help the patient address their medical problems. If they have type 2 diabetes, are they taking medication as prescribed? Are they having side effects? If so, can you talk to the doctor prescribing about that? Of course, behavioral issues, depression, anxiety, alcohol, post-traumatic stress disorder, and then lifestyle. Obesity is a major problem globally tied to a diet high in fats and sugar, low in vegetables and healthier foods. Physical activity, we're increasingly spending more time at our desktop at work. We're spending more time watching our screens, watching our Netflix shows, or watching our Facebook accounts, less time being physically active. So these are the kind of roles and duties a social worker would have practicing integrated healthcare. And again, I know in the United States, the social worker would be in the primary care clinic, but you could also be a social worker in a village, talking to patients in their home, doing integrated healthcare. It doesn't matter what setting you're in. It's more about your mindset in terms of being focused on the whole person, their physical health and their mental health. That's integrated healthcare. There are a couple of models of integrated healthcare that are very popular. One is called the primary care behavioral health model. This means a social worker or a psychologist is part of the medical team working in the hospital or primary care clinic. The physician will literally take the patient and say, please see my social worker down the hall, might even walk the patient to the hall, introduce them to the social worker, and have the social worker begin doing their assessment. The approaches are brief interventions, typically 3 or 4, maybe 5, 6, 7, 8 interventions total. It's not long-term therapy, it's more short-term therapy. It's often done in group education format, teaching patients skills, coping with depression, how to stop smoking, how to increase your physical activity and lose weight. So it's very practical and it's very focused on the immediate patient needs to improve their physical and mental health. Another model that's a little more complicated is called the collaborative care model. This is also very common and probably the most researched model. Basically, the social worker is also part of the medical team, but they're really playing a role to outreach patients who are have certain problems. They might do phone calls to patients who have diagnosed with depression and have obesity or diabetes. They'll try to engage the patient, offer health coaching, help them improve their depression. They'll track their progress over time, what's called a patient registry, a database of patient names to follow and keep track of. It's a long-term approach because we know for chronic conditions, both physical conditions and mental health conditions, they don't change quickly. Have you tried to ever change your diet? Have you tried to stop a bad habit like not exercising or tobacco use or too much alcohol? It's hard to change our habits. It takes a long time. It takes typically months of effort before you can successfully overcome and change a habit and have a more healthy habit in its place. It's about team-based care, having the social worker work with the physician, the nurse, specialist, the family, of course, the patient. They're really a consultant. The social worker often will offer educational and consulting services to the physicians, talking about what is depression, how do you treat it, how do we help patients improve their physical activity and diet so they can lose weight, how do we help patients stop smoking. These are all things a social worker be trained to do and work with the family physician to offer them a great service. You know, we know physicians and nurses often look down upon social workers as not being equal professionals with them. We find in the United States that's often the case too. A physician might think, well, I'll take the social worker as an intern. I'm not sure how they're going to help me. I have a busy medical practice. I have many patients needing medical care. And after a few months, the social worker offering help for these patients on stopping smoking, losing weight, managing depression, the doctor suddenly recognizes the value of the social worker. It's a way of increasing your value in the healthcare system. Now, again, I'm not familiar with in detail. I look forward to you teaching me about social work in Peru and South America. But I know other parts of the world where I work, there are social workers certainly available, often doing community-based work, sometimes working in the hospital, doing hospital work. And that the more we can find social workers willing to take on this new role, the better. And there's a great need to train social workers in these models of integrated healthcare. And that's been my focus for the last 15 years. doing training for social workers first in China, then Southeast Asia, more recently in India and Bangladesh. And I want to talk about some of the adaptations to do practical training to make sure the information I'm providing to social workers is realistic. They can learn the information. So I don't try and do complex, long academic training. My training is very practical. I use the phrase learn today, practice tomorrow. Here are some of the competencies I see social workers needing to do integrated healthcare. They must, of course, know about the models, the role of the physician and the nurse, how to conduct a health risk assessment, how to use patient engagement techniques. One is called the 5 A's. I'll cover that today. How to motivate patients with motivational interviewing. How to use brief interventions for psychological problems like depression. How to use new habit change interventions for unhealthy lifestyle habits. And the good news is there's great resources available. There are strategy techniques that have been proven effective that can be used by social workers with very little training in psychotherapy. One of my colleagues in Vietnam is training community health workers, lay people in their villages to do behavior activation and approach for depression, and finds they do a fantastic job. She's done research showing depression improves with a lay person that learns about depression and offers this treatment protocol. So I'm very optimistic. These are things social workers can learn without too much difficulty. It takes more intention and persistence and effort, not anything that they can't master given their professional role. So first of all, health risk assessment. Maybe if you go to your doctor for a checkup, you might get a questionnaire where it asks you questions about your sleep, your diet, your physical activity, maybe about your mood, your depression, physical symptoms, aches and pains. That's the health risk assessment. And they have them now. They cover very briefly, maybe about 25, 30 questions you can get information about 12 different problems. Some of them more lifestyle, diet, exercise, sleep, some more psychological depression, anxiety, post-traumatic stress disorder. Others more physical symptoms. And of course, your health status medically. Do you have elevated blood pressure? Do you have elevated blood sugar? A health risk assessment is a way of quickly finding out what kind of problem does the patient have. Especially with aging, we're facing the problem of multimorbidities. Patients often have multiple problems. An older patient might present to you with type 2 diabetes, being overweight, having excess lipid levels, high lipids, being depressed, tobacco smoking, or using alcohol harmfully. Multiple problems. Where do you start? By doing a health risk assessment, you get a quick idea about the kind of problems the patient has. You can then talk to the patient where to start, which problem to start with first. For patient engagement, I use an approach that's been widely used globally called the 5 A's. That stands for assess. Maybe you give out the health risk assessment first of all, do an interview diagnosis assessment. Advise, give the patient advice. My problem list shows you have depression and obesity and maybe alcohol use. Here's some common treatments we can offer you for those problems. Next is a new key step, agree. You come to agreement with the patient where to start. If you tell the patient you have problems with smoking, obesity, and diabetes, where do you want to start? The patient might say, well, I've been trying to stop smoking, let's start there. Wherever the patient wants to start, that's the place to start because that's where they're most motivated. Then we assist and arrange for the treatment plan and follow-up visits to make sure they can work on the plan identified with you. We use motivational interviewing, a technique to increase motivation to change. And then we use the stage of change model called the trans-theoretical stage of change model to see where the patient is. Are they ready for change? Not ready for change? Are they already engaged in change? Here's a quick summary of the 5 A's. I'm not going to cover it in detail. My time is not sufficient, but basically you give the patient advice after you do the assessment. You come to agreement, work on a treatment plan, then arrange for follow-up. This model is great for helping the patient and clinician be on the same page and agreement on the kind of problems, on the same page for a plan, and a plan to follow up to make sure the patient can take the effort to work on that plan over time. I've chosen brief psychological interventions in my work globally based on those that I think are the best fit for the skill level of social workers, for example, where there's not much training for social workers on psychological interventions or lifestyle counseling. So I chose these topics here: motivational interviewing, behavior activation for depression, problem-solving therapy, cognitive behavioral therapy, and mindfulness-based interventions. I'll give you examples of a few of these right now. I'm also going to talk about habit change interventions. There have been some fantastic recent publications and research on new approaches to habit change that are very easy to follow. They're not complicated. And they involve how do you improve nutrition? How do you improve physical activity, reduce tobacco smoking, reduce people that are doing too much gaming or screen time. So the good news is there are new approaches. Now, habit change is still very difficult. I don't like you to misinterpret my words, but we have newer techniques I'll summarize today that are much more intuitive, easy to follow for patients and for clinicians. Here's some examples. I'll give examples of behavior activation and mindfulness. So behavior activation, some quick sayings here. Plato, the great philosopher, lack of activity destroys the good condition of every human being, while movement and methodical physical exercise save it and preserve it. The Chinese proverb, be not afraid of growing slowly, only be afraid of standing still. Movement is medicine for creating change in a person's physical, emotional, mental states. So movement. We know physical activity is good for mental health and of course good for physical health. Behavior activation is a brief approach to improve depression, also used for other kind of problems like anxiety, for example, that can be done briefly in anywhere from 3 to 5 sessions. They can be individual sessions, group sessions, online. And you're having the clinician ask the patient to increase their activity levels, to help them do more every day. Because when you're depressed, you often withdraw. You just want to stay in bed, watch TV, not do anything. You lose interest in things you used to do to enjoy, like talking to friends, going out and doing things. So with depression, you lose interest in being active. With behavioral activation, we're going to try to boost their activity because we find if you become more active, that by itself will reduce depression for most people. So the theory behind behavior activation is that our mind and our mood are related. When the patient is depressed, they withdraw, avoid things. They cope by withdrawing because they don't feel like interacting. They're just feeling down and sad and having no motivation. They stop doing things they used to do and enjoying, like going out, maybe walking, visiting their neighbors and friends. They might even engage by looking at unhealthy behaviors to relieve their depression, like alcohol, smoking, unhealthy food. And we know from research, if you increase physical activity, any kind of activity, social activities, that can break this vicious cycle. The vicious cycle is I'm depressed, I avoid, become withdrawn, I get more depressed, I get more withdrawn. By adding more activity level, we can break that cycle. And as the patient begins doing more, their mood will improve. Their mood will follow their activity and their action. That's the theory behind the behavior activation model. You begin by keeping a daily record, having the patient write down what they're doing every day, hour by hour. Have them do it weekly for 1 week and come back and review that with you. Next, you have them go over their life values. What kind of things are important to them in terms of relationships, their career, their role in the home, recreation, hobbies, mind, body, spirituality, daily responsibilities as homemaker, worker, taking care of an adult parent or child. You find out what kind of things are important to them because you want to try and have them create activities that are close to their values that are important to them. The more they're close to their values, the more important it is, the more they're likely to be motivated to try these things and get back into them. You have them simply rank the activities they picked from the most to least difficult. And you start with the ones that are least difficult first. Well, I can walk up and down my stairs in my apartment. I can do that for 5 minutes. Great. We'll start there. Not trying to walk 5,000, 10,000 steps. Let's try and walk them down your stairs. Take a small goal that's realistic. And give them a sense of things to work on to begin increasing their activity based on what they think they can do. Had the patient go home between sessions, begin working on in a calendar, keeping track of their daily activities, adding to their calendar, I'm going to take a 5-minute walk in the morning. I'm going to visit my neighbors and chat at lunchtime. I'm going to go with my colleagues after work and take a walk. You try and be realistic, plan things that fit their schedule. If they don't complete it one day, try and go back the next day and do it. So it's a way of using a calendar to simply plan activities and try to do them. And they're rating their mood the whole time. So that when they first do a baseline, they might rate sitting in bed, watching TV. How's your mood in that hour? Oh, it's a 2 or 3 out of 10, very low, very depressed. Then they find out if they go out and go and visit their neighbor next door, go out and go to the local park for a walk with their spouse or friend, their mood is suddenly rated 6 or 7. They begin to see, oh, if I do more, I feel better. They can become convinced just from their own experience this is a helpful approach. And last of all, they try and find somebody in their social environment to help them, their spouse, their partner, a friend, a coworker who can help to sign a contract to work with them, to help nudge them to do these things and become more active. So that's how behavioral activation works. It's evidence-based. It's been proven effective. It's as effective as cognitive behavioral therapy. Now, cognitive behavioral therapy, or CBT, is excellent, but we know it takes a long time, 8, 12 sessions. It's more complicated. Behavior activation was developed as a component of cognitive therapy, and now it's actually a standalone because it's shorter, faster, and as effective as CBT, as effective as antidepressant medication for depression. So it's evidence-based, easy to teach, easy to learn for social workers, and what I widely have them use in my work. Next, I'll cover mindfulness. I'm not sure how many of you do meditation. Mindfulness is a kind of meditation that was developed by a psychologist in the United States named John Kabat-Zinn. It's taking mindfulness approaches from Buddhism, but it's not Buddhist practice. It's a secular practice using mindfulness meditation principles to help people become more aware of how their body responds to stress and what kind of emotions and thoughts cause them to stress, and give them the skills to better observe their emotions and thoughts that are causing distress and find ways to cope with them more effectively. So it's really a short-term approach, takes 6 to 8 sessions, to use mindfulness meditation approaches to teach people how to better recognize in themselves their physical stress, their mental stress, their emotional stress. And once they recognize that without reacting to it, they can start making ways to change that using mindfulness meditation practice. So there are many kinds of meditation. I like all of them. I prescribe all of them, but mindfulness is very structured and very specific. It's defined as being aware by paying attention in a sustained and particular way, on purpose, in the present moment, and non-judgmentally. You don't judge what you're thinking. I've been practicing mindfulness almost daily since 2016. I find it very helpful in my life to manage my own emotional, psychological issues. It's a self-help tool. I've gotten training and mentoring from other professionals on mindfulness practice. So it's widely available and also evidence-based. So mindfulness, why do we need mindfulness? As human beings, we tend to avoid unpleasant emotions, unpleasant thoughts. We don't want to feel bad. And we often find that when we have these thoughts pop into our head, they're about things in the future. I'm worried about this job task tomorrow. I'm worried about this test I have tomorrow. I'm worried about my bills being due next week and have not enough money to pay for them. Or I might be thinking about things in the past that happened already. I wish I had not let that person push me out of the way in the line. I wish that person hadn't argued with me and maybe a bad outcome. We often think about things in the past or future that make us worried, upset. And mindfulness is about being in the present moment to recognize what's happening right now and better understand the emotions and thoughts we have and how to better cope with them. We often use avoidance of the negative emotions and thoughts by engaging in unhealthy behaviors. I feel depressed. I'm going to binge on Netflix and watch my favorite show for the next 3 hours. I'm going to have some nice chocolate cake or fried food for a snack because I feel depressed and I'll feel better if I have that. I'm going to smoke a cigarette to feel relief of stress. I'm going to have a glass of alcohol. We often look for things that are unhealthy to help relieve depression and depressive thoughts. We are avoiding things, and mindfulness helps us to be in the present moment, accept these thoughts and feelings without being judgmental, without reacting to them, and then finding ways to cope with them. So the solution for practice is to focus on the present moment, learn how our body responds to stress by doing things like breathing exercises, a body scan of all of our body sensations, observing our emotions and thoughts as they come into our head during mindful practice. The typical session is 8 sessions of mindfulness, or 6 to 8. Each one has very specific skill being taught. It can be done individually, in group, online. Typical session, the clinician will welcome the patient, I'll talk about the theme for the week. They'll do practice of mindfulness in the session. They typically take 5 to 10 minutes. They're not lengthy. There'll be a group discussion about people's experiences to mindfulness, maybe some more practice, some more discussion. And then homework assignment. Each session introduced a new type of mindfulness practice and gave the assignment for the next week for homework. Go home and practice that once a day and come back for the next session. The first session is about the breath, using the breath as an anchor, meaning it's an anchor to the present moment. If you stop now, just take a deep breath and think about it. Focus on the breath, the sensation going up in your nose, into your chest and your diaphragm. Exhaling. Focusing on that breath brings you to the present moment. That's one of the key initial basic skills of mindfulness. The breath is always there. It's free. It's accessible. It connects your mind and your body. Then we go to other kind of mindfulness techniques and practices. These are some of the examples of the kind of sessions and the things we talk about. We do the body scan, where you talk about learning how to scan your body from toes to your head to understand sensations and especially stress in your body. We all experience stress in different ways. Some people clench their teeth. Some people get a tight stomach. Some get headaches. Some get tight neck or back. We have different ways of experiencing stress. We aren't often aware of that. So we learn from mindfulness, what are our ways of responding to stress physically, become more aware of that, and use mindfulness to relieve that stress. I'm going to cover next habit change. So again, if you ever tried to change your habits, there are some great new approaches being promoted. There's a book called Atomic Habits by the author James Clear that's sold millions of copies globally. And basically, it's looking at a habit. What is a habit? It's an acquired mode of behavior that's become involuntary, something we do over and over again. So for example, in the morning, maybe you wake up and you make your coffee or tea. Maybe you make a certain breakfast every morning. Maybe you, after breakfast, brush your teeth or wash up. You do these things every day the same way. You don't think about them. You don't think, I'm going to make the coffee. Now I'm going to put the water into the coffee or teapot. I'm going to turn the heat on. You don't think about this. You just do it automatically, involuntary from habit. That's a habit. You do something so often, it becomes something you do without thinking about it. And that's a good thing. If we have habits, we don't have to think about things, we just do them. You get in your car or scooter to drive to work, you don't think about how to drive a car. You know from habit how to do it, and you take the unconscious steps to follow that habit and execute it daily. We can use the science of habit change to develop new habits. We have a habit loop is the key. Habit loop describes how habits are started, initiated, and maintained, as well as how to change a habit. So the habit loop includes, number one, a cue, a craving, something causes us to want something. In response to that, we execute a habit or a routine. We do something, and it's rewarding. So this is how habits are formed. I'll give you an example. Let's say you're walking down the street, going to work, coming home from work, and you walk past a food stand, a little cart on your way home, and you smell the wonderful fried food in the stand. It smells good. You glance over, it looks so good. This is a photo of a food truck in Thailand where I've traveled. It just looks so good, you have to try a bite. You have to go ahead and buy some. So one day you buy it, so delicious, feels good, even though we know having too much fried food is not healthy, right? Too much salt. Next day walking past, I think I'm going to try it again, just this one time today. And someday every day you're walking past that stand, buying something every day, maybe even buying 2 or 3 pieces because it's so delicious. That's how habits are formed. Any kind of a cue will alert us to a demand, a need for something, and we follow up on the need with our habit, and it's rewarding. The cue, our response, and a reward. That's the basis of how habits are formed. So we use that to make the science of how to start a new healthy habit. First, pick a small routine, something tiny. I'll meditate for 5 minutes. I'll eat 1 healthy fruit or vegetable during lunch today. Set a reminder. Try and do it the same time every day. Every morning, I'm going to practice mindfulness meditation for 8 minutes. Put it in your calendar for a reminder. Maybe you can tie it to an existing habit. After I have my morning tea, I'll do a 10-minute meditation every day. You want to make this new routine, this new habit, something you repeat every day at the same time and place, ideally, because that's how habits are formed, by repetition. The more you do something the same way, the same time every day, over time it becomes automatic. You don't even think about it, you just do it. That's the key for habit change. We take steps to practice habits, make them routine until they become unconscious automatic habits in our life. That's how we add a new healthy habit. You can use a little worksheet for this. Identify the current habit you want to add, make a calendar, and create a habit intention. I will have a piece of fruit for my lunch every day. At lunchtime, in my office, in my home, with my coworker, with my spouse. Make a detailed list of what you're going to be doing, and then try and put it in your calendar and make reminders. You can even use your phone for a reminder, give yourself an alert to do a new habit. So to me, this is a very simple way of adding new healthy habits. Old ways of doing habit change were very difficult, complex. Patients often give up. This is the simple way. It's evidence-based. There's emerging research on this is effective. So here's simply an example of a 4-session approach to doing habit change. Explain the habit loop to the patient, have them decide on a new habit they want to add, give them homework to go ahead and do the habit change intention, have them come back a week later, look at their progress, maybe introduce habit stacking, and repeat, repeat, repeat until they become automatic behaviors. That's how you add a new healthy habit. Replacing an existing bad habit is more difficult. Unhealthy habits more difficult. Let's say if my habit is I have an argument with my spouse, and I respond by withdrawing and having alcohol to calm myself down. The alcohol is effective. It removes the conflict. I'm no longer fighting with my spouse. I feel relaxed from the alcohol. But we know it's not an effective way of coping. It's a short-term way. And with abuse, it can even become another part of the problem you're dealing with. So to find a new habit, we have to replace the alcohol and find something else that's rewarding. So I might say, let's use mindfulness. I'm not with my spouse. I'll withdraw. That's okay. I need a break. And I'll practice mindfulness for 5 minutes. That's a healthier way to find a way to relax from the argument, to focus on the moment. It's rewarding. I feel relaxed. I go back to my spouse and talk some more. Here's an example of replacing an unhealthy habit, alcohol, with a healthy habit, mindfulness. This is how you replace an unhealthy habit. You got to find a new habit that can replace it because the cue is not going to go away. You're still going to have an argument with your spouse. You're still going to see that food stand with the wonderful food. You've got to find a way to replace the bad habit with something that's more healthy and positive. So I developed an online training program the last 2 years. I had a small grant. I developed a curriculum for social workers in University of Labor and Social Affairs in Hanoi, Vietnam. We developed a course there. I did training with that course with colleagues in social work universities in India and Pakistan and Vietnam. So we have an online program. Right now, it's being moved to an online asynchronous platform. You can take it on your own without instructor help. Typically, each session is 90 minutes of work in terms of watching a video, doing some reading, doing practice, doing some role play with a colleague. It's on Google Classroom, uses WhatsApp as a way to have text chat with each other and with the group leader. There's a competency scale, integrate healthcare competency that you'll take before and after the course to measure your learning. So it's a very accountable learning environment with satisfaction surveys you complete to make sure you're satisfied with the presenter, with the content. It involves practice. You get better. Without practice, you're not going to learn something. The content I just covered with you now, I made the core content. I have 8 different modules in my first course, Integrated Healthcare. They're right here. I just covered these already. And to give you the skills to do each one of these activities. The training includes didactic learning, watching webinars, reading assignments, discussion with your colleagues taking the course, using WhatsApp for question and answer with each other, doing practice, practicing doing a PHQ-9 for depression, practice doing the 5 A's with patients or with your colleagues. You have responsibilities to view the webinars, to complete assignments, to be active in discussion, and learn by doing. If you don't try things and practice things, you're not going to learn. So this is a very hands-on, active course. It's not academic. It's not about reading and doing research. It's about learning and practicing new skills. Now, of course, there are barriers to integrate healthcare. Certainly globally, I know in Southeast Asia and South Asia, my guess is also in Peru and South America, there's a lack of government resources and funding for social workers to work in hospitals and primary care healthcare clinics. There's a challenge of how do you find a role for social workers to do this in the healthcare system. They're not respected oftentimes by physicians and nurses by healthcare leaders. Find recognition for social workers is critical. We need to assess the current competencies for social workers for integrated healthcare, offer training to improve their competencies. Those are all barriers. Facilitators, things that are helping us to promote social work, we know that the social work basic education is well matched. You already learned in social work, or the values of social work are patient-centered care, advocacy, involving the family. Those are all things that are critical for integrated healthcare also. We know that healthcare leaders across the globe, Ministry of Health, for example, recognize the need to address health behavior change to improve diabetes and hypertension, for example. Healthcare costs are increasing for medical care. That's not a good thing for economies. They want to try and reduce healthcare costs. So we know from research, when you integrate healthcare, it can help reduce costs by reducing the need for expensive medications, reduce the need for hospitalizations and visits to the emergency room. We need local champions like my colleague Habib, my colleagues in Vietnam and Southeast Asia to try and help train social workers on these new approaches. And we need to have stakeholders in hospitals and primary care also wanting to accept social workers to practice and try these new techniques out with patients. So in summary, I'll say that we have a global epidemic of non-communicable diseases, of psychological distress, unhealthy lifestyle problems, all increasing. Our physicians and nurses are only trained in medication, which is helpful, but not sufficient. If you have type 2 diabetes and you're still drinking too much alcohol and you're overweight, eating unhealthy foods, your diabetes will get worse in spite of taking medication. Without behavior change, we cannot help people improve their life. We have to have these kind of techniques to prevent disease in the first place. If you can prevent obesity and unhealthy diets, you can prevent diabetes from even starting in the first place. Some great recent research by a company in the United States called Virta, people with type 2 diabetes go through diet change. They reverse their type 2 diabetes, become non-diabetic from lifestyle change. It's not easy, but the fact is it's evidence-based. We know we can change health behaviors and prevent or reduce or even reverse many chronic diseases. And in my view, social workers are ideally suited. I've trained social workers first in China, then in Vietnam, then Thailand, Cambodia, now India, Pakistan, and soon Africa. So I'm happy to share these resources with any of you, happy to try and connect with you in Peru or South America or other parts of the world and share resources. My goal is to broaden global integrated healthcare. And with that, I will stop with some extra time here and be happy to take any questions. Thank you all for your attention and your willingness to stay with me on this conversation. Hopefully it's helpful. And that ends my presentation for now. Thank you.
Thank you so much, Dr. Ronald, for being here, for your participation. And it's a very important subject for us, where we are here in Peru and in Latin America. No, we don't have the special course of clinical social work in our universities, and even in my country, we don't have a master's still, but we have options now in Puerto Rico, in Spain, in other countries, no?
That's exactly right. That's right. I mean, for example, I always practice cultural humility. So this is my first time talking to a clinician from Peru. So I would want to learn from you, what is the culture there in terms of health behaviors, depression, lifestyle? I need to learn from you first. And then what is the workforce? If there are no social workers available, can we use community health workers? Can we train people in the community? Can we train existing nurses or physicians? So I always look for the entry point, where to start, being very practical, but also being very humble. I need to learn from you to have any benefit and help in your country and in your work you're doing.
We have a big statistics in mental health, and we have a specialists in even psychologists. No, we don't have so much people who are psychologists or social workers who specialize in these subjects as mental health. Even people work in institutions, but they still don't know how is the methodology or the procedure, how to act.
That's exactly right. On the one hand, medical providers like doctors and nurses don't have training in mental health. and mental health providers don't have training in how to help medical problems. And the good news is, if you're trained in psychotherapy and you can do cognitive behavioral therapy for depression, it's not difficult to learn how to do behavior activation, how to do habit change interventions. It's very similar approaches. They're easy to learn, but then you have to raise awareness for psychologists and social workers. My patients with depression probably have problems with overweight, with poor lifestyle, with stress. I can offer more than just psychotherapy. I can offer health coaching. That's the hope I have globally. We can have more and more professionals on medical and mental health side learning about whole person holistic care to better improve our patients' physical and mental health. They go together. You can't take them apart.
Yeah, I see. And in your country, well, is most of the social workers are clinical social workers in it. And when you finish the career, in the United States, you have to study a course for being clinical social work, or just you leave the university being social work?
Well, I mean, the social work education,
Clinical social work, sorry.
well, there are
Clinical
certainly
social.
there are social work degrees. Habib can talk about that. Bachelor's and master's, even doctoral social work. And if that workforce is available, yes, you can learn these techniques as part of your training and practice. If you haven't got that available in your country, then certainly you can train other healthcare professionals, emerging, healthcare leaders and clinicians or community health workers on these techniques. The good news is they're not difficult to learn. I've seen my colleagues in Vietnam train thousands of lay people living in their community, their small villages, to become health coaches and improve depression, improve diabetes. So it's not easy in terms of making these steps to happen, but it's proven effective. It's proven it can be done. It just takes the right champion like you and the right effort and team to do so.
However, I think that you have a comment for Dr. Ronald.
Yes, always I have good comments for him. He's the very smartest professor in social work, and he's a great inspiration for my life, for my other colleagues and my volunteers in Bangladesh. Because Dr. Ronald, he is a very close friend of mine. He is the advisor. He is the advisor of editorial board of our International Community Talks newsletter, and the best comment for him is a professor of social work who I found 24/7. When I need him, I just send a text, and he has been inspiring me always. And he's a great leader for integrated healthcare. And we are working on integrated healthcare global perspective. He has a great focus long over years in Asian countries like Vietnam, Cambodia, Hong Kong, China, Bangladesh, right? And recently we have been thinking for a collaboration research on integrated healthcare, focus on patients care and training for the social worker inclusion in integrated healthcare. That would be the new dimension for Bangladesh. So it's it's my immense pleasure with this platform when I just see Dr. Ronald's face on the poster. Actually, it gave me excitement that we must be
You got
meeting here
surprised.
online. Yeah, of course, of course. Because Carolina, you didn't tell us, but when I see the poster that Ronald is there, that was
He
great meeting
knew,
really.
he knew. When we were coordinating, he said, "Oh, I know my friend Navigor." Oh yeah, really? But I didn't say anything until just get
Yes,
vision.
you were very successful, Carolina, really. You can manage him to, he's too busy person really in research work or social work. So we are eagerly waiting to see him in person. Though I met him last year in USA, Dr. Ronald's conference on integrated healthcare. That was a big journey for me, and that was a great experience of meeting him. And one thing I should announce here, Dr. Ronald will be the keynote speaker in our next Congress hosted in Bangladesh by CSWPD Foundation on 14th of November to 16th. So Ronald will be joining us as keynote speaker on 14th morning, Bangladesh time. And we are eagerly waiting to see him in person with my volunteer team and my colleagues next year or late this year so far. We're just in,
I look forward.
Yeah,
Well, thank you for the
it's
kind
coming.
words,
So,
We've been very grateful for those kind words. Thank you. And thank you for being my teacher and learning about healthcare in Bangladesh and Pakistan. Thank you.
and I should add a few comments with Dr. Ronald. Actually, I was some cases missing his talks because we are preparing on conference preparation, but it was actually loud speaking. I was just listening, moving around and listening in my office. But the thing is, the secret is he always follows healthy lifestyle, actually, that he focused on his presentation to live longer, and that expressed in his face and appearance. When I met him in USA, he is such a man. He counts every seconds to produce good articles, good thoughts in academia, and also nourish a good healthy lifestyle that we should follow. Really, I'm just telling you that I found him there in that time. Thank you, Ronald. Actually, you are a great inspiration in my life. So,
Thank you,
so
Steve.
far, I
That's
think
very
in
great. I'm
academic
very grateful to hear
world.
that. It feels very good to hear
Thank you.
that. And same to you.
Thank you.
You motivate me to help the people of Bangladesh to
Thank you
improve their
so
health.
much.
Thank you, Abby, for your words, for your comments, and really we appreciate Dr. Ronald, all your speech of today, and we will follow your suggestion. No? I need a lot of that is to know about the food also because
It's great to meet you also. Thank you for inviting me. It's wonderful meeting you. Hope we can talk again sometime soon.
okay. Well, Dr. Ronald, what will be your finally word for the audience who is watching you and will watch you later, no, for the
Just thanks for the opportunity. I hope to learn more about Peru and South America, and many other colleagues on this call I saw from India, other parts of the world. So I look forward to my ongoing global collaboration and trying to make more contacts. If you watch this video recording and want to contact me, use my email and please reach out to me. Happy to talk to you and schedule a time to chat on Zoom or WhatsApp. But thank you for the opportunity, and I wish you all well in your own careers and your own championing of social work. I will say the last comment, by way of humor, I'm a psychologist, but I love social work, and so much so my wife is a social worker. So dedicated to their career and their profession.
That's great. That's great. Thank you so much, Dr.
Thank you.
Ronald.
Bye-bye. Goodbye, all.
Thank you, Dr.